narcotic prescribing and narcotic use in our community and prevention of death. So when I started thinking about how can we engineer safety, I looked into our electronic medical record. Around 50-60% of physicians are using electronic medical records now. And within that, we have drug-drug interaction capabilities of documenting. We would have systematic means of identifying high-risk patients that should be screened more closely, and that we can incorporate evidence-based medicine into the EMR. If we use E such as education, we should be educating our communities at a population level about the significant social impact of narcotic use in our community. We should be educating all healthcare workers. I was talking to an anesthetist yesterday who teaches at Queen's University. We discussed how little education there really is, both at postgraduate and undergraduate level, regarding safe prescribing habits and appropriate screening tools to patients. And it has to be across the continuum of healthcare professionals where we educate. Now, on enforcement, we have to use data to properly monitor prescribing habits, educate and enforce improved prescribing. In particular, there's going to be a drug monitoring system that is in play right now and has been in play for the last year in Ontario that can monitor prescribing habits of physicians. But once that's finally in play, we should be able to compare prescribing habits across different professions in the different areas of the province. And if you have an anomaly in your prescribing habits, that should be investigated in a scoping review. There should be education provided to a physician. And if that education doesn't modify or change prescribing habits, there may be other avenues for the College of Physician Surgeons in Ontario to pursue. As well, under the Excellent Care for All Act and Health Law in Ontario, all family health teams and CHCs should be incorporating quality improvement plans within their practices. If we really wanted to push for safety, we would ask the ministry to ensure that all family health teams and CHCs incorporate quality improvement plans regarding narcotic prescribing in their practices, given that we have the same number of deaths from prescribed opiate use as we do have from motor vehicle accidents. And we should be pushing that there is a significant economic benefit to our community by decreasing overall drug use and decreasing the societal costs of drug use. And clearly, to do this, we have to address the fundamental environment, the determinants of health, root causes. This is how we can approach improving safety of narcotic prescribing within our communities and within our practices. Eyes Wide Open is a great opportunity for all of us just to start dreaming of how we can have better safety and better prescribing for our communities. So thanks again to Michael Parkinson for this opportunity to dream. And clearly, doing no harm is part of the Hippocratic Oath, and we must all be thinking safety first and have a path to perfect safety within our prescribing. And it starts with us in our family practices and our specialty clinics whenever we prescribe. And it should be built in. Now, I like using the rule of D's. The first D is getting the right diagnosis and ensuring that you've worked through differential diagnosis appropriately, and that you are using opiates in the right place in the clinical pathway. And if you do pick an opiate as the right drug or treatment pathway, you use the right dose for the right duration and for the right time. And basically incorporate pathways, clinical pathways that have already been researched and proven by evidence to be effective through the National Pain Center at McMaster, which is a website I will be showing later. And that we incorporate opioid managers, for example, in all of our prescribing. So the EMR can be set up, the electronic medical record that is being used by primary care can be set up to ensure that you put the right screening tools in whenever you're going to potentially prescribe opiates to a patient. You do whatever screening test has the right evidence behind for that patient. In particular, our specialist, when we had our meeting last year, recommended the opioid risk tool. It's designed to predict which patients may develop aberrant drug-related behavior, and it's evidence-based, scored appropriately. And it was their suggestion that we include that for any patient that is prescribed opiates. And this would be perhaps something that if college physicians and surgeon inspector came by and looked at your prescribing habits, whether you had evidence that you provided any type of screening tools. As well, before initiating opioid therapy, the National Pain Center suggests you do a comprehensive assessment of patient pain condition, their general medical condition, etc., their psychiatric status, and substance abuse history. So making sure you get the right diagnosis, you have the right differential diagnosis, and that you're prescribing the right drug for that patient. And then you do provide addiction risk screening tool, so significant level evidence for that. We also discussed in our meeting using urine drug screening for baseline risk and compliance. And along that line, having a opiate contract with the patient whereby they understand that they have to provide a urine drug screening to ensure compliance with the medication. And that patients always be reassessed on a regular pattern to ensure efficacy of the opioid treatment. And that all patients are discussed the risks of medication, the benefits of the medication, potential adverse effects and complications, and that no medication will ever get rid of 100% of the pain, and that we have to have realistic goals set for pain management. So for data sources, clearly we like valid data sources that are reliable, that are available, that are timely. And if we set up the EMR as a means of monitoring prescribing and incorporated safety into the EMR, that's a data set that we can be data mining on a daily, weekly, or monthly level, and comparing prescribing habits within a family health team of 20, 30 doctors, and also using it as a quality indicator. I also show this slide because as part of the EMR, you should be doing electronic prescribing, that we shouldn't ever be handing paper prescriptions to patients when we're dealing with narcotics, and that we have to have our unique identifier, the patient unique identifier, listed on the prescription. And when I was working at Queenstown Health Team, we electronically or we fax these forms on a daily basis to the pharmacist, and we had agreements with pharmacists that they would only receive prescriptions through this format. So it's building safety into all of our prescribing habits and following appropriate guidelines. And these guidelines are now approved by multiple colleges. They become a standard of care. And once it's a standard of care, you can compare and contrast your prescribing habits against best evidence. And the college can use this as a standardized tool for enforcement. The opioid manager was shown to us at our meeting last year, and it seemed to be a great way, if it was incorporated into an EMR, of being able to identify all of what I previously mentioned. Before you write your script, you get the right diagnosis, look at risk factors for the patients, what goals you've decided for the patients, you had an initiation checklist, overdose risk, and perhaps prescription of Narcan if that's potentially a risk. You monitored your risk tool, and you've talked about the right dose for initiation and a trial chart. So you're following the patient longitudinally. And most physicians who saw this thought that this would be a great means of integrating safety within their practices. And the flip chart on this opioid monitoring tool, it had the maintenance and monitoring, and then when to stop opioids in aberrant drug-seeking behavior, just as a prompt to let you know when you're seeing certain behaviors that you should be questioning prescribing habits to these patients. In particular, recurrent prescription losses, aggressive complaining about the need for higher doses, harassing staff for fax scripts or hidden appointments. Nothing else works. That what was told to us at our meeting sort of catastrophic thinking that patients are presenting with. It should be a clear signal and warning that you should be looking at your prescribing habits for that time location. We have to engineer these types of guidelines into our practices and into the EMR to really have integrated safety built in, and that you cannot prescribe unless you've done the screening tools that I mentioned. And what we used at Queen's Family Health Team was a treatment agreement. So we went through the screening tools. We had a written, signed, and dated treatment agreement that the patient and physician agreed to one prescriber, one pharmacy, that there were written and discussed consequences for earlier replaced prescriptions. There was regular follow-up, urine testing as required, open communication between all caregivers to that patient, and in particular, good liaison with the pharmacist. The surveillance is an ongoing, systematic collection, analysis, interpretation, and dissemination of information for action. And I mentioned earlier, if we had a good surveillance system in monitoring mortality, we've been picking up some rise in mortality from a change in prescribing habits back in 2004, 2005. And we need ongoing surveillance to be able to monitor this, I would say, significant population health issue. If you look at population pyramid, and Brian Schwartz from Public Health Ontario and myself worked on this in terms of what data is available in Ontario if you want an integrated surveillance system. And certainly death data is the tip of the pyramid. Hopefully it's the least frequent occurrence, but it's the most sensitive and specific, and often is associated with a complete toxicology report. So that data is exceptionally important for us to continue to monitor at a provincial level and ensure that that death rate decreases over time, and that the conversion to obscenity does have a population benefit. The other data that's important to monitor is all admissions to hospital. And we monitor a surveillance system here at KFLA that monitors around 73 hospitals right now. We monitor presentations to the emergency department. So what hospital, what date and time they show up, and what's their chief complaint. But we also monitor admissions. And I'll talk about the strengths and weaknesses of that surveillance system. I think also what's important is, as an emerge doc, family doc, if I had a patient that was quite complicated with overdose, I would call it the Ontario Poison Control Center, and they record those conversations and calls and are a good source of complex as well as community calls regarding overdose, and can be an ongoing significant source of data. Connects Ontario is also a good source of data in terms of opioid abuse, helplines for addiction, CAMH, and admissions to hospitals for addiction would be another important signal. Health units are involved with harm reduction programs and needle exchanges, and that information from the street is exceptionally important for changes in drug pattern use at a local community level. And that can enable improved decision making by our health partners, both the prescribing partners as well as emergency response. And to monitor overall drug use, monitoring use of Google, use of Facebook, Twitter, and have signals built into those to look at drug patterns on a regional or provincial basis, somewhat similar to what we do for Flu Watch. We are privy to information about how many hits there are for patients querying flu, or fever, myalgias, arthralgias. There's definitely a clear correlation between outbreaks at a population level and those queries within Google. And I would think a drug surveillance system on a population level might benefit from investigating Google for that same pattern. If you talk about the pyramid, so for every one overdose death in 2010, this is from the U.S., there were at least 733 non-medical users in the community having complications. There were 108 patients with abuse or dependence. There were 26 ED visits for misuse or abuse, and 10 admissions to hospitals. So in terms of, this is a reverse of the pyramid, it all stems from the death. The death gets the community aware, but you have to be aware of all the other consequences to the healthcare system of that one death. It really does represent 733 other non-medical users of the drug that we have to be monitoring in a robust surveillance system.